everyone. My name is Dr. Jim Drzegescu, and I'm the Medical Director for Chicago Health Colleagues. We are happy to bring you this video presentation on PSA and prostate cancer. It is my pleasure to introduce Dr. James Silora. Dr. Silora is a board-certified urologist who's been on the staff at Palos Hospital for the last 20 years. He received his medical degree from the Loyola University Stritch School of Medicine and did his urology residency at the University of Minnesota Hospital and Clinics. He has a special interest in robotic and laparoscopic surgery. I should also mention that he is a second-generation urologist. In 1995, he joined his father, Dr. Hermie Silora, in practice. Dr. Silora.
Hello, my name is Jim Silora. Thank you, Dr. Drzegescu, for the kind introduction and inviting me to speak on this topic that is important to me and should be important to all you and your patients. Let's go over prostate cancer and PSA. Prostate cancer is the second most frequently diagnosed cancer amongst men in the United States. About 190,000 cases are diagnosed every year. And this is more recently, even with PSA screening guidelines having changed. It is also a deadly cancer. It is the second leading cause of cancer death amongst men, claiming about 33,000 lives per year. The average age of diagnosis is 66, and early diagnosis is actually quite important because we want to find these cancers before they become metastatic. If we can find them in the localized state, the 5-year survival is close to 100%. If it is metastatic, that survival rate, 5-year survival rate, will drop down to 31%. So this is where the controversy comes in. For us urologists, we see the ravages of prostate cancer. We'd like to find it early, but let's get into the controversies regarding prostate cancer screening. The screening question has been a real conundrum since PSA has been found. The issue is always to screen or not to screen. The confusion comes in what's a good cutoff? Does the PSA velocity matter? What age should we do the PSA screening? Does PSA density come into play? What do you do with free and complex? There are all these new tests, PHI, PCA3, 4K, there's SELECT. Now we've thrown in multiparametric MRI. It causes a lot of confusion. So when you have this kind of confusion, that's what the urologists, I guess, are there for, to figure out what to do with all this. But we can definitely understand why there's a lot of confusion. Added into this is the greater confusion of all of our societies. The USPTF, the American Academy of Family Practice, have studied the data, lots and lots of data over years to come out against screening altogether. ASCO has recommended no screening for asymptomatic men less than 10 years life expectancy. The AUA itself is not totally clear, but says PSA screening should be done with shared decision-making. A lot of the controversy is based on how the data was collected. So as we look at it, and this data is starting to come out, the studies have been shown that when they compared the screening arms on all of these studies to the non-screening arms, unfortunately the patients were not screened. A huge percentage of them were actually screened. So no difference was found in the ultimate result because they were basically comparing two very similar populations. So this is a very difficult thing because it's hard to find patients who have never had PSA and allow them to be watched over time. So how do we resolve all of this? Our recommendation in urology, and my recommendation, is that we need to screen appropriately, not indiscriminately in everybody. So we need to go over how we decide who should get it and how often they should get a PSA and move on from there. With PSA, The cutoff that we use for proceeding to a biopsy or urology consult is very important. And the concept is if we increase the cutoff, we will decrease the sensitivity. So the higher we put that cutoff, the more difficult it will be for us to find cancer. But the specificity will go up. So it's such that if we put the PSA very high, we will find a lot of cancers in those patients, but they might be too late. So we need to balance the sensitivity and specificity. So using a cutoff of 3.0, the sensitivity for finding any prostate cancer is about 30%. So if we raise that PSA up to 4.0, the sensitivity will drop down to 20%, but our specificity will go up to 90%, whereas before it was only 85%. So if we increase the number, we sacrifice on sensitivity, right? But the higher number gives us a better specificity. We will go over age-adjusted PSAs to try and adjust this based on age. We want to be a little more sensitive when we're younger, on our younger patients, and a little less sensitive on the older patients because they're more likely to have problems with other comorbidities, and it's not quite as important to find a slow-moving cancer like prostate cancer in the older age group. Digital rectal exam by itself is not very sensitive, mostly due to inter-observer variability. But if there's a nodule felt, it's fairly specific for a malignancy, so specificity for digital rectal exam alone is 90%. Positive predictive value for PSA of greater than 4 is 30%. So that's not really very high. If we break it down to PSAs between 4 and 10, you have a positive predictive value of 25%, and the chance of finding organ-confined disease is 75%. But if we wait until the PSA goes above 10, then the positive predictive value goes up to almost 60%, but the chance of finding organ-confined disease is less than 50%. So as physicians, we like to find these cancers, significant cancers, earlier, and we'd like to find them before they're metastatic or ideally when they're still organ confined. Okay? What kind of things cause the PSA to go up and down? And this is one of the confounding variables that makes this test so difficult to understand. So things that make the PSA go up are BPH, urinary tract infections, prostatitis, any sort of instrumentation like a catheterization or a cystoscopy or something like that. Obviously cancer. There's some rise in the PSA from sexual activity. Bike riding has also been known to do this. If they're sitting on that seat for a long time, it sort of presses on that prostate, and their levels tend to go higher. And if they stop that, sometimes it'll go down. What sort of things will drop the PSA? Well, one of the most common things is finasteride and Avodart, or dutasteride. If a patient has been on these medications for more than 6 months, the PSA will drop by 50%. So on our side, if we see somebody's been on finasteride for a while, we will, for more than 6 months, we will always double the PSA to get a true reading of their PSA. And this is actually quite important to find some of these cancers because if they're on finasteride, you have to adjust your threshold for sending them to the urologist or having a biopsy. Ketoconazole has some effect on the androgen axis and steroid axis, so it can also cause the PSA to go down. And saw palmetto may cause a little bit of a decrease in PSA, but not significant enough to cause a lot of problems. What is screening appropriately then in all of this? Well, the way we think about it is PSA is really used to find small cancers early. So we like to use it for patients who have long life ahead of them. So they need to have a greater than 10 to 15-year life expectancy if we're going to use PSA for screening. So this would be most important people between the ages of 50 and 70. Average life expectancy nowadays being 75, 76. It is going up all the time, but if they are very, very healthy and they want it, then maybe we will do it, but it's usually best for patients with life expectancies greater than 10 to 15 years. Now, a new concept will be to have PSAs done when at that age, but you want to look at that PSA and say, if their PSA is low, do they need to continue to have PSA screening? And what we found after studying, Dr. Crawford did this study where he looked at the database at Henry Ford and checked how many people had cancer when their PSA was less than 1.5. And he found that it's quite rare for patients to have prostate cancer diagnosed within the next 5 years when their PSA was less than 1.5. So if your patient has a PSA less than 1.5, it probably doesn't pay to keep getting the PSA every year. You can probably increase the interval on that patient to every 2 years or every 3 years or even every 5 is what we're starting to see. So if you're going to do PSA and you're going to look at that number, if the absolute number is less than 1.5, you can consider increasing the interval and eliminating all this anxiety over PSA testing. Age-adjusted PSA is something that you need to be aware of. Younger people have lower PSAs than older people because BPH is more common in older people, and as the prostate grows, the PSA may go up. So our threshold for sending them to the urologist for an elevated PSA will go up as the patient gets older. This accomplishes two things. If we put the threshold of the PSA higher in the older patient, we will find less cancer because we won't be checking as many people. And that's a good thing. So you don't want to be jumping at every PSA in a 70-year-old man. You want to make sure that that's a significant PSA rise before you will do it. So when they're younger, though, if they're, say, a young man of 50 years old has a PSA of 3, that's too high for us. So we would rather the PSA be lower at that age. So the threshold for him, because you want to find the cancer early, should be lower. So screening is always indicated in those patients who have high risk, say a family history of prostate cancer, father or brother who had cancer before the age of 65 and it was high grade. Black Americans are notorious for having high-grade prostate cancer, and so those people will usually need a PSA at least 1. And then going back to the 1.5 rule, if their first PSA is less than 1.5, you can probably wait, but the ones with the strong family history, I'd probably do it every year anyway. So what is our goal in urology? We want to find the significant cancers. We agree that the low-grade cancers are probably not worth looking for or not worth treating anyway. We do try to minimize the number of biopsies that we do. If you send it to the urologist these days, you'll probably notice that if they just come in with 1 PSA, we want to repeat that PSA to confirm that the PSA is truly elevated. So we don't like to use PSA alone to decide whether a biopsy should be done. We will still do the digital rectal exam because some cancers will not produce a lot of PSA and will be high grade. So say a Gleason 8, 9, or 10 cancer, it wouldn't surprise us to feel a hard nodule and the PSA be completely normal. So we don't feel that DRE should be eliminated, but it's not the best test because there's a lot of inter-observer variability on that. We also use a lot of adjunctive tests like 4K and Phi, and that's sort of out of the scope of this discussion. But we will use those usually if we've done a biopsy and we're sort of looking for an excuse not to do another biopsy. Informed decision can be done by both the urologist or the primary care physician, but I do believe the primary care physician has a lot on their plate. For us, this is in our wheelhouse. We're more than happy to discuss PSA screening or PSA testing with any of these patients once it's been done. But mostly it's done on the basis of what are the risks of a biopsy, and what will the biopsy show, and the different treatments afterwards. And that can be quite a lengthy discussion. We don't do a lot of discussing too much about the actual screening testing of PSA with the patients. Most of them already come to us wanting to have it. But if they ask, we will discuss with them all the risks of the biopsy, the pain, the digital rectal exam, and so forth. And we go from there. So where do we think a urology consult is best? In the younger man, when the PSA is over 1.5, those patients should probably be watched very carefully. And once it gets above 2.5, should probably send it to the urologist and have them take a look. That's when the risk of prostate cancer starts going up. It should be corrected for any patient on finasteride and Avodart. I do think that needs to be stressed because we do see a lot of people who are sent to us with a PSA of 4 on finasteride, and by that time it's already 8, and that's a bit worrisome for us. In terms of velocity, a PSA rise greater than 0.75 nanograms per deciliter per year would prompt a concern for us, and we'd be happy to see those patients because they do need to be monitored more carefully. At the very least, they need another PSA, usually within 6 months, to make sure that rise, see if that rise is consistently going up or if it corrects itself. What about age-specific PSA? We discussed this earlier. The way I like to think about it, make it simple, is between the ages of 40 and 50, the PSA should be around 2. And you can do, and between 50 and 60, it should be 3 or less. And 60 to 70, it should be 4 or less. You can add 0.1 for every year. And so let's say a 55-year-old guy should have a PSA of 2.5 or less. If you want to be that, you want to cut it down that low. It's just a simple way to decide when you should be worried and when you shouldn't. If you want to make it less sensitive and more specific for prostate cancer, you can raise those cutoffs by 0.5 or a whole point if you like. That way you end up decreasing the number of biopsies necessary or consults sent to urologists where they may do a biopsy. But for me, this algorithm seems to work pretty well. It makes for a quick calculation in your head as to where the PSA should be. What about over 70? That's the age group where a serious discussion about prostate cancer screening needs to be done. And then over 75, we recommend no PSAs unless there's some sort of a symptom that would prompt it. And that could include a very suspicious digital rectal exam because many of these prostate cancers are not symptomatic, and we'd prefer to find them before they're symptomatic. But since when you're over 75, greater than 10-year life expectancy issues start to come into play, we would only treat prostate cancer or intervene on prostate cancer when it was palpable and high grade and preferably symptomatic. What are the myths about PSA that are out there? Well, a low PSA rules out prostate cancer, sort of. But when you have a high-grade tumor, there are times when it does not produce PSA, so this is not a hard and fast rule. Other ones are, if the DRE is normal, there's no need for a PSA. And that is actually backwards. If the DRE is normal in the age-appropriate patient, the PSA is the only thing that's going to allow you to find a significant cancer. So I would say that you need the PSA if the DRE is normal more than the other way around. The other myth would be PSA is not needed after prostate cancer treatment. So this is another thing that goes on with that we see is when patients have had their prostate out, they ask a lot of times, well, why do I need a PSA anymore? The reason that we use the PSA is because it's the most sensitive way to find out if the cancer has recurred. And this is true of also radiation, but it's not quite as useful. But after a prostate has been removed, say from a radical prostatectomy, the PSA should be 0 or less than 0.1. So anything above that would indicate some form of recurrence, and we would want to get on top of that before it got out of hand. What about multiparametric MRI? This is something that has come up in the last 3 or 4 years. A lot of patients asking about it, going on, asking the Google doctor, and the Google doctor says, multiparametric MRI is the greatest thing ever. And it's good, but it's not the greatest thing ever. It does improve our ability to find high-grade cancers. And the way this works is an MRI is taken of the prostate. The radiologists go through hundreds and hundreds of images, and they say, yes, I think I see something that looks abnormal in this part of the prostate. We then see the patient, and we can take our ultrasound and fuse it to the MRI and actually target the biopsy to that lesion and see if it's cancer. The more abnormal the radiologist calls the lesion, so we have a grading scale of 1 to 5, anything grade 3, 4, or 5, PI-RADS grade 3 or 4 or 5, we would do a biopsy on, and the higher the grade, the higher the PI-RADS score, the more likely it is a high-grade tumor. It's still done under ultrasound guidance. It's still done in the urologist's office. The MRI is used to target the biopsy. Now, why would we not want to do this all the time? Well, one, it's very expensive. The other is that insurance companies have not really decided that this is the way to do as a first biopsy. So this is mostly used for patients who have had a negative biopsy, and now you're looking to see if you missed something on the first sort of random biopsy that you took, the systematic 12-core biopsy that we do. So to do this on screening everybody, if you think PSA causes a lot of unnecessary costs, doing this will just shoot that right through the roof. So the indications for this are usually a prior negative biopsy with a continuing rise in the PSA, okay, or a patient who has a low-grade cancer that we are going to actively watch, and we just want to be sure that there isn't another high-grade tumor that is hiding inside the prostate. So we will usually do the biopsy. It'll come back low-grade. We'll say active surveillance, but we will want a multiparametric MRI 4 to 6 months later to see, because we need the swelling and the inflammation from the initial biopsy to go down. We will get another MRI, and if there's an abnormal lesion there, we will do a targeted biopsy. Okay? So primary biopsy in some areas of the country will pay for multiparametric MRI, mostly at the patient's request. Most urologists are not asking for this, but things could change. It will increase the cost of doing a biopsy for sure.